Hello, my name is Isaac Nichols, a pharmacy PGY1 resident at Oklahoma State Medical Center. Today we'll be talking about the research project, Appropriateness of Direct Oral Anticoagulant Prescribing for New-onset Venous Thromboembolism and Non-valvular Atrial Fibrillation. This research project was also worked on by Dr. Lyndsey, Dr. Leah Rappsilber, and Dr. Jessica Gwartney. Background information. So traditional agents that we've used for treating non-valvular atrial fibrillation and VTEs were either IV only, being heparin or low molecular weight heparin, or were old oral agents such as warfarin. Both of these classes of agents had some fallbacks such as extensive lab monitoring and higher rates of bleeding events compared to some of these newer oral agents such as the DOACs, apixaban and rivaroxaban, as well as some of the direct thrombin inhibitors such as dabigatran. Recent studies across the nation and surveys have kind of shown new problems with some of the prescribing centered around incorrect dosing of these new DOACs. Primary reasons being renal function changes, drug interactions, as well as indications from AFib as well as VTEs. The primary purpose of what this research study is going to be is evaluating the appropriateness of the prescribing patterns here at the OSU Medical Center for apixaban and rivaroxaban, specifically in pulmonary embolisms, DVTs, and non-valvular atrial fibrillation. Our primary methods of what we did in our study, it was a multidisciplinary quality improvement initiative by retrospective chart review analysis of previous patients that had been at our facility. The investigational medications that we looked at were rivaroxaban and apixaban, and we looked over the time period of January 1, 2021 to April 30th of 2021. Our inclusion criteria were patients age older than 18 years old, diagnosed with new-onset non-valvular atrial fibrillation or VTE, prescribed one of the investigational medications. Exclusion criteria included pregnancy, previously prescribed one of the investigational medications, and previously diagnosed with non-valvular atrial fibrillation or a VTE. Primary patient demographics that we looked at included age, gender, race, height and weight, BMI, drug regimens that they were on, as well as drug interactions. Our primary endpoints that we looked at were number or percent of patients with appropriately prescribed DOACs, being rivaroxaban or apixaban, for new-onset non-valvular atrial fibrillation or VTE. Our secondary endpoints we looked at included number or percent of patients with readmission due to a recurrent VTE or bleeding event within the following 30 days after prescribing. This was divided up based on BMI categories for each of the patients. And also we looked at mean time for dose adjustment, whether that be renal dosing or drug interaction dosing, and transition from alternative anticoagulants prior to being started on one of the DOAC agents. Demographic, we have looked here at 38 in the non-valvular atrial fibrillation group and 41 in the VTE group, being primarily even through the two difference. Gender-wise, we had primarily male in the different groups, being 55% versus 53% in the non-valvular and VTE groups. Average age between the two was primarily different, between non-valvular being older age, averaging about 70, and VTEs being of younger age at 57. The range that it was over was VTE was 20 to 83 years old, and non-valvular atrial fibrillation 47 to 92 years old. So a pretty wide range for the VTE, which might have something to do with why the age difference was so significant. Height average, it was primarily the same, less than 2 centimeters difference between the two. Weight average, The primary range was about 55 kilos to 145 for non-valvular atrial fibrillation, and VTE being 59 to 163. The primary average weight was 92 for non-valvular atrial fibrillation and 97.5 for VTEs. The BMI was largely the same between the two groups, being around 31.5 to 32.7. The race difference between the two, non-valvular atrial fibrillation being primarily white and Caucasian at 78.9%, VTEs also a primary majority being 58.5%, but having a less significant majority than the other group. A significant difference was also seen in Black or African American group, being only one patient out of the non-valvular atrial fibrillation, making up 2.6%, as opposed to 6 patients, being 14.6%, in the VTE group. The following different race and ethnicities down and below were somewhat different, being that there was one being Native Hawaiian or Pacific in the VTE group and none being in the non-valvular atrial fibrillation group. Drug interaction wise, there was the majority of drug interactions being with aspirin or clopidogrel, the antiplatelet agents often found for some of the comorbidities that these patients did have. Another common one was SSRIs being an increased bleeding risk, and others such as phenytoin or Prescribing being a drug interaction issue with some of the metabolism. Primary endpoints that we did see in the non-valvular atrial fibrillation group, we did have 81.58% correct prescribing of the apixaban and rivaroxaban combined. Incorrect prescribing was only 18.42%, being the majority apixaban, but rivaroxaban, given that there was only 3 out of 6 being correct, the higher percentage. In the VTE group, there was similar kinds of correct prescribing at 87.8% combined and 12.2% incorrect between the combined apixaban and rivaroxaban. Our secondary endpoints that you can see in the chart on the right, the non-valvular atrial fibrillation group with bleeding and VTE events had 1 bleed due to apixaban in the BMI 30 to 35 group, 1 bleed in rivaroxaban at the 20 to 30 group. In VTE, there was only 1 bleed in the apixaban, again in that 30 to 35 group. Important to note here also, there were no recurrent VTEs that occurred, and all of the bleeds that did occur were subsequently handled at the facility. The next endpoint that we have secondary was time to dose adjustments. In the non-valvular atrial fibrillation group, the apixaban was 0 hours to adjustment, and rivaroxaban was 69.67 hours for renal adjustment. In the secondary, the time to transition from other anticoagulant was non-valvular atrial fibrillation, about 4.29 days and 3.07 days for apixaban and rivaroxaban respectively, and VTE was 1.31 and 4.21 days for apixaban and rivaroxaban respectively. Important to note here, in the secondary time to dose adjustment, the VTE group does not have any dose adjustments that were needed for these. So discussion for these results that we've seen, from the primary endpoint, 18.42% were incorrect prescribing for non-valvular atrial fibrillation, as opposed to 12.2% for incorrect prescribing for VTEs. There was a higher rate of incorrect prescribing in the rivaroxaban group overall, being 36.36% versus only 13.33% for apixaban. There was numerically more for apixaban, but there was also the vast majority, 60 out of the 71 charts that were seen, were the apixaban prescribing, and only 11 being rivaroxaban. The most evident difference was found in the non-valvular atrial fibrillation population, which had a 50% incorrect prescribing rate for rivaroxaban. Primary reasons for incorrect prescribing was due to overdosing based on the criteria for non-valvular atrial fibrillation in apixaban, being the 2 out of 3 criteria being a serum creatinine greater than or equal to 1.5, an age greater than or equal to 80, and a weight less than or equal to 60 kilograms. Other overdosing issues was found with renal function in rivaroxaban, so renal dosing adjustments for creatinine clearance less than 50, as well as indication for apixaban being an overdose. These patients were prescribed the loading dose 10 milligram twice daily for 7 days, as opposed to just having 5 milligrams twice daily or 2.5 depending on the renal dose adjustments for non-valvular atrial fibrillation. Underdosing, the apixaban criteria also here. So there was an incorrect underdose at a 2.5 as opposed to the 5. Indication for apixaban, these patients were prescribed the 5 milligram or 2.5 milligram BID dosing as opposed to the 10 milligrams twice daily for 7 days that is required for the loading dose for a VTE. Also, indication for rivaroxaban, similarly, a loading dose period of 3 weeks at 15 milligrams twice daily was not given, as opposed to just a 20 or 15 milligram daily dose that was needed for non-valvular atrial fibrillation. The last primary reason for incorrect prescribing was a drug interaction that was found with apixaban combined with phenytoin, which is an X contraindication that was not taken account for when prescribed. Primary results from the secondary endpoints: the time to dose adjustment in non-valvular atrial fibrillation group with rivaroxaban was slightly skewed due to one patient having a 216-hour difference between the actual dose adjustment that needed, which skewed the level of our average range pretty significantly. All 3 events of the adverse events were GI bleeds, none of them being a VZE that was recurrent. One of them occurred within 5 days of prescribing, one within 10 days, and one of them was an actual rebleed after a patient had had a GI bleed on admission. In conclusion, the rate of incorrect prescribing was slightly less than at other facilities based on previous studies that they had done at their respective facility, but the primary reasons for incorrect prescribing seem to remain similar. Predominant reason for incorrect prescribing was adjusting for renal function or for the specific 2 out of 3 criteria for non-valvular atrial fibrillation in the apixaban group. Addressing this gap in care, we will be periodically giving education for the prescribers, being the residents, as well as some of the attendings at OSU Medical Center, as well as a collaborative patient care with clinical pharmacists being on the groups that round with the internal medicine as well as family medicine teams to inform them on differences in prescribing and being on the lookout for any adjustments that need to be made. Additionally, we'll also look into implementing a check system into the electronic prescribing system, our EPIC system that we use, to prevent some of these errors from occurring, whether that be a required field that needs to be filled out based on indications, as well as some of the criteria that are there for specifically apixaban. That can also be implemented to see if we can cut down on some of the incorrect prescribing rates. That is all that we have today for this specific research poster. Thank you for your time.